Palliative, and heart failure is a really interesting condition, as we'll talk about, because it's common and it's unpredictable. And that's part of the challenge, but it's also part of the fun. Um, I'm a geriatrician. I'm now at the University of Western Ontario, Western University, and I'm a clinical researcher there. And I've been doing work on chronic disease management for frail older persons for a while, both in long-term care and primary care. And in particular, I've been interested in heart failure for a couple of reasons that will become evident to you. I was part of the Heart Failure Guidelines Committee for 15 years, and I finally said, you need to get somebody new. So I left, and they did. But, and I do an awful lot of work in the setting where again, the focus is not necessarily on cardiovascular disease. There's different focuses, and I've had a lot of interesting experiences working with teams and working with families of patients with heart failure. Some died most died very well, but how things turned out, I could never have predicted. And so, again, without further ado, I'm going to start with a case. And maybe people can put their thoughts in the chat or raise their hands. But this was in a new nursing home, and I was just there for the first time. And I was asked to see this man because he had behaviors that were attributed to dementia. So he was 91 years old and had been newly admitted to the long-term care home. And they thought he had day-night reversal because he was up all night and very agitated, very confused, and would call out for his wife. And so they figured it was adjustment to the nursing home, which is not, that makes sense. They were wondering about anxiety. Someone had read about weighted blankets and thought maybe he could use a weighted blanket. But we did a history. We looked through his medical history. And the interesting thing is that he had had coronary artery bypass surgery over 20 years before this presentation. And a few years before, he had had a stent put in. And at that time, they said, well, you've got a lot of coronary disease and we can't do anything else, medical management. He never had heart failure diagnosed. And so, we thought, look, he's had coronary disease. His bypass grafts are 25 years old. Let's go check this out. And we brought the team. And what was fascinating with this guy is he did not endorse any of the classical symptoms. Are you short of breath? No. Do you have trouble sleeping? No. I mean, he had cognitive impairment, but what was interesting is he denied the symptoms. And so we lay him flat and his face turned blue. And I asked him, are you short of breath? And he said no, as he was breathing really fast. Sat him back up. He did better, gave him some diuretics. He had all the features of heart failure on physical examination. We treated his with him diuretics, and his agitation went away. And it was heart failure, and the heart failure had presented in that manner. I don't think a weighted blanket would have been a good thing for a guy who can't breathe. But this is an example of why this disease in older people is so interesting, because it presents in ways that, unless we're attuned to that, we might, I mean, it's quite logical to attribute this to dementia or anxiety or to adjustment disorder. And so it's important to realize that their symptoms are not typical at all, and that he could be treated using the usual meds. So you probably guys all know this, but heart failure is really, it's a syndrome. It's a syndrome that's a physiological disturbance. It's not something you can biopsy. It's the physiology is deranged because there's something wrong with heart function or structure. And it could be valvular, it could be cardiomyopathy, it could be myocardial infarctions in the past, reduced left ventricular function. It could be a stiff heart, doesn't really matter. The response of the body is to try to maintain cardiac perfusion by loading up on extra fluid. and that's where you get the edema, and that's where you get the pulmonary congestion. And in some cases, they will feel rather, hypotensive because of lack of perfusion. But really, this is the issue: is the heart's not working, and the body responds by accumulating fluid. The body cannot tell the difference between dehydration, where perfusion is poor, and heart disease when perfusion is poor. Our bodies are designed to respond to dehydration, so they respond by retaining fluid. In the setting of heart disease, that's not a good thing. So the epidemiology of heart failure in long-term care, if you look at data that was collected very carefully with physical assessments and things like that, it's about 20%. And I presented this data to Schlegel Villages. I'm not picking on them, but I work there. And I looked at using the CIHI database, yourhealthsystem.ca. You can all go to that website and you can all find the quality indicators for what all nursing homes in Canada, except Quebec, because they don't use the MDS. So what's interesting at Schlegel Villages, it's about 11%. Rivera in Ontario is 9.6. Extended care is about 10%. And that's about right. About only half of heart failure is actually recognized. Now, I broke it down by villages at Schlegel Villages, and Winston Park was the anomaly there. And that relates to the fact that I've been working with them for a very long time. And I've worked with the team, and we have a system whereby they go out and they can detect heart failure by engaging with their team. And they're at about a 20%, which is what the literature says they should be. Everyone else is down below. And so that's sort of a bit of a foreshadowing that, we need to find this disease before we treat it. And because it is a bit of a sneaky condition, it's hard to diagnose. We're going to talk about precisely that. How do you engage with the team to do so? It's also important to understand the trajectory of heart failure. As you all know, the cancer trajectory. Then there's a frailty trajectory where people sort of slowly lose their function, and we see that often in Parkinson's or dementia. Then there's the organ failure trajectory, and heart failure classically follows that organ failure trajectory. Although in some studies, heart failure patients do all different sorts of trajectories. They could die suddenly, they could die like a cancer patient, they could dwindle and be frail, or they can do this, which is the more classical one. So basically, the issue is that people get an heart failure exacerbation, we treat it, they get better, they're well for a while, they get another exacerbation. It's sort of the cycling of the condition. And the thing is that every time there's an exacerbation, their functional capacity overall declines, and it declines over time. And eventually the exacerbations get more frequent because they're getting renal disease. As you'll see, they're getting dementia and they forget to take their meds, so they have more frequent exacerbations. They have multimorbidity, and so they get more and more precarious, and eventually they'll die. The death, again, is very tricky because you could die with that first heart failure exacerbation. You could die when you go home feeling better, and then you die, or you can die at any point, and often people will sort of eventually pass away in long-term care. They go from independent community living to needing home care and rehab, and eventually, like we noticed, 20% of people in long-term care have a history of heart failure. Some of them now go to hospice, but unfortunately not enough, and there's reasons for that. Because related to the difficulty in predicting things, and we have set it up in a way that we're looking for a due date, which is easier for some diseases than heart disease. And so what makes it even more tricky is that, oh, there's a new drug, let's try it out, and whoops, their function has improved. We've pulled the rabbit out of the hat. And that can happen. And I've seen it in all sorts of settings, including long-term care, when I had an older guy who was falling all the time, and we put him on Entresto, a low dose, and his fall stopped because his heart failure was stabilized. And so the drugs work in those older people. You have to be a bit more careful, but they work. But eventually they will resume that trajectory, right? We pull the rabbit out of the hat a few times, and eventually there's no more rabbits, and they will achieve a terminal phase. Throughout this, in the 1970s and 80s, before ACE inhibitors, heart failure had a 70% mortality at a year. People did not live very long. And the drugs now have changed this. I've had patients who've survived over 10 years. And even in long-term care, I've had one who survived 7 years and she died of lung cancer. She lived long enough to get lung cancer. And so the drugs work, but obviously the longer you live, the more complex things get. And so by mental health, cognitive impairment is very important. Frailty sets in. There's more falls, there's more risks. The caregivers get more stressed and they use the healthcare system more. And so the management gets challenging such that by the time they get to long-term care, it's tricky. The goals of care will obviously change. And so early on, people are interested in living longer as well as better. But towards the end of life, we're really not looking at longevity, we're looking at quality of life. And really for heart failure, a palliative approach to care is critical because this is what happens to them. And while early on they may not have too much in terms of disease burden, things get more complicated. And so you really have to have an ongoing conversation to figure out what goals of care ought to be and what matters to them. Optimal heart failure therapies, optimal for the person, actually work fairly well even to advanced stages. People look at me and they say, "Are you sure?" All the data that's out there suggests that there are impacts on reducing hospitalization, maximizing functional decline, and even preserving cognitive function. And that patient that I've had for 7 years who died of lung cancer, we tried all sorts of things, but she could eventually tolerate Jardiance and a beta blocker and some slow doses of spironolactone, and it worked for her, right? She stayed out of heart failure. She learned how to recognize her symptoms. Her daughter was involved. And with the long-term care team, we were able to, she had a very decent quality of life for those 7 years. And so the drugs are good palliative care drugs. We're not thinking mortality anymore, but they are good for symptoms. And again, the importance of always engaging, right? It's sometimes they have dementia, but sometimes they're still able to learn. And often with the caregivers is to bring them into the team to monitor the symptoms, talk with the nurses, tell the PSWs something's up, but always, 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 especially if there's been an exacerbation or it's your annual, define the care goals and see what they want. And so ultimately, ideally, we may not increase lifespan, but we can soften the landing and make the trajectory somewhat more gentle. So I will get through all of these things. So one of the things to remember is, to palliate properly, you need to have a diagnosis. And it sounds obvious, but um, as you've noticed, so long-term care homes in Ontario have about 11 to 10 to 11% diagnosis rate, where if you look at the literature or you work with a team to improve their diagnosis, they can double that. And that's because there are classic features that we all learn about. And in long-term care, frail older persons, everyone's got leg swelling. So it's not that specific. Shortness of breath is tricky, although sometimes they are. And sometimes, they say, I like to sleep in my bed with the head up. And then why is that? I don't know. I can't breathe. Okay. And that's a clue. Gut pain, bloating, ascites, those are the classical ones. And of course, you have the symptoms from poor cardiac function, which fatigue, weakness, loss of muscle mass, cold extremities, that's very nonspecific also. In older persons, however, delirium or an acceleration of their functional decline or taking to their bed and falls, Problems at night, new onset of difficulties at night are pretty specific. Worsening sleep, more urination at night. And I remember someone, nurse, coming to me and saying, I don't know what's going on with her. She's not herself. And she was lying perfectly flat. And her chest x-ray showed pulmonary edema. And she hadn't read the book. She wasn't orthopnic, but that's the way it was, right? And of course we treated her and she got back to herself. We gave her diuretics and she got better. And I think that's the tricky bit is if you keep the possibility of heart failure in mind and you use the usual approaches of physical exam and getting a chest x-ray and even taking a diuretic trial and they get better, then you've done your job. You've got the diagnosis, but you've also made them feel better. So critically engaging your teams is the way to achieve this. And we'll talk a little bit about that. So we conducted a scoping term care. It's hard to manage stuff in long-term care because you've got less and less staff. And even though we all got our $200 check from the government, yay, staffing has not increased. And so how do we make use of the teams that we've got? So in general, disease management interventions in long-term care improve knowledge of heart failure among the teams, improve communication, improve job satisfaction. We've got some nice stories from Winston Park. Increases prescribing and does reduce acute care utilization and costs. And so it seems to work. But one of the key things, and I think that's one of the interesting jobs, is to try to get specialists to come out of the hospitals and maybe help out in long-term care a little bit more. So that seems to be an important intervention. How do you organize care? And so I'm thinking more in terms of, you've got new residents coming in, and it's always a busy time. And what we'll show you is that that time of admission is also when the highest rates of heart failure events happen. And so how do you find out who's going to run into trouble quickly? Who might have the disease? Who do you need to see now or see later? And that's part of the chronic disease management of being more proactive and prepared. Who needs to be involved? Everyone. The physician or the nurse practitioner looking after the team, enhancing the team with the people you're working with. The RPNs and the PSWs can be easily trained, and I'll show you how, to be part of the team, to recognize patients, to help monitor them. And again, I think the specialized services, I have a cardiology colleague, and it was very exciting for her because she visited a nursing home for the first time. And she was very excited. And she was excited because there was all sorts of heart disease. She had no idea. We have to know and anticipate and design things to understand that risk changes over time, meaning some people will stabilize and then they'll get a heart failure exacerbation, and it won't happen on schedule. It'll happen when it happens. And so how do you pick it up early before you get a phone call on Saturday night that so-and-so is hypoxic? And so how do you change the system of care so that you can anticipate when a transition happens, identify it early, treat it early, and resolve things? All right. So I'll talk a little bit more, and I talked about the anticipation bit, and I think that's really important to think about it, is that you may stabilize patients for a very long time, but there's always ebbs and flows. And picking those up early will prevent suffering and will keep them out of hospital. So what are the determinants of care in nursing homes? And I don't know if there's any specialist services involved here, but I remember in the pandemic when all the internists decided to have a virtual on-call system, the specialists are out here. What really determines care quality in long-term care is the team. Collaborating to provide resident-centered practice, and collaboration and trust and communication are critical here. and that includes the attending physician, nurse practitioners, and the entire team. Engaging with the resident, engaging with their family. Those are the main determinants of care. If you don't sort this out, you can have out, but you haven't sorted out and helped the team. And so it's very important to think about that. In Canada, we like to create external solutions for problems that or things that are deemed to be problems internally, and that never really works. So this is where the resident here is, and that's where the special make your way to the center here and help out. So how do we do this? How do we integrate? So the first thing, and again, this may not sound terribly clinical, and we can talk about meds and things like that, but you guys all know how to prescribe these drugs. And and then we can provide some information about them, but really the issue is you must start at the organization level, and you have to start with data, quality indicators. What is your heart failure diagnosis rate? If it's 10%, all right, there's room for improvement. What are the critical care processes that if, and then let's build the capacity within the team. So we'll go over this. Um, Quality assurance is interesting because we never really learned about it in med school or nursing school or anything like that. And I think now it's coming. And so thinking about data is very important. Issue with this. If you don't, you don't. That's fine. If you're doing great and you have low admission rates and a high detection rate, then you're probably doing fine. And then the teams have to use that data to think about whether they should implement the intervention. Data, and now you've got to look at your data on a regular basis. And we see that now in residency programs where they tell residents to go do chart reviews periodically. Very labor intensive and very hard to sustain. Long-term care collects tons of data, and you can look at it and bring in the entire team and look at your data and see how you're doing. Look at other people's data. Go to that CIHI website and how do you compare? If you have lower falls rates, then great. If you have higher this problem or that problem, then okay, you've got something to work on. And for heart failure, if your diagnosis rate is low, then okay, do we want to start looking at this? And if you do that on a regular basis, as you start, for example, uncovering your heart failure cases, you can feed that back to the team. It's positive feedback. We're doing a better job here. And it sounds very administrative, but really the only way you can end up with the learning health system is by using the information with the team and taking some time once in a while to look at how you're doing. So you want to set that up first. The next thing you want to think about is the care processes. So you have a new resident coming in, and they usually have a long medical history and a pile of medications. And if you're focused, right, how then do you assess the person efficiently? How do you mobilize the entire team? As physicians, I know that in long-term care, the payments are better than in retirement homes. I worked in a retirement home, but it's still tough. You've got a lot of people to see. And so how do you mobilize the team and get their observations to help out with the diagnosis? Like that patient, he was in acute heart failure, so you got to deal with it. I always put there, review the advanced care wishes. Maybe it's his 25th heart failure exacerbation this month, and he's done, he's fed up. Or maybe it's the first one. So you want to stabilize and treat acute symptoms according to their wishes and try to stabilize things. And then the fun is in the chronic management. So again, always anchored with patient goals and advanced wishes. How do you engage your team to monitor symptoms, engage the patient and their caregiver? How do you communicate? How do the PSWs communicate to a nurse if they say, hey, this is so-and-so's legs are getting swollen because her socks are tight on her ankles, right? We know she has heart failure. We think it's happening again. How do you get that team to do that? And then you will obviously want to balance that with all of the other conditions. Eventually, they will become unstable. So again, why? And do they wish to have treatment, or are they done? Do they want to palliate? If they want to treat, then fine. Manage and stabilize. If not, then you can switch to end-of-life care, right? Remembering that, and we'll talk about the meds, like ACE inhibitors are good for shortness of breath. Narcotics are also helpful, oxygen, fans, but you've got all these protocols. But you want to think about the care processes so that you can, all of this is done to anticipate and mitigate and prevent a very bad deterioration or a bad outcome in terms of symptoms. So the key bits we want to think about are an incoming resident, physician rounds, shift change from the PSW nursing perspective is a very important opportunity. How was the night? Weight monitoring. Everyone rolls their eyes about that one, but that's your early warning system. And you don't have to do it every day. We've tried it and we've shown that you don't have to, but you should do it once in a while. And then obviously people may get sick all of a sudden and you have to deal with it. Well, we'll skip the last one, but we'll talk about the others. So new resident, if it says on the chart, history of heart failure, then the odds ratio that this is heart failure are 15. So you can probably take that to the bank. The histories of orthopnea, the classical symptoms, if they're there, is specific, but a lot of these folks don't have these symptoms. And all their chests sound crackly, and most of them have edema, so it's not terribly useful. But if it says heart failure or fluid on the lungs, because we like to use that euphemism, then they probably have heart failure. And so these are the data that we did. So we reviewed over 500 charts, and about 20% of them had a history of heart failure. And those are the key bits: the history of heart failure, a history of coronary disease, and if they happen to be on a beta blocker or Lasix, a diuretic, then you should probably worry about heart failure and probably go see them about that. That's all you really need to do. Who do you see first? Well, they've all got a RI home care done when they come in. And in the RI, don't look at the whole form. Go to the back where it says personal health profile. And you look for the CHESS scale. CHESS is a health instability scale. And what you see is this is data from long-term care in 3 provinces. And you can see we compared people with heart failure to no heart failure at different CHESS scores. So 0 is stable, 5 is really unstable. And at 3, you start to see a bit of an inflection here, right? A CHESS score of 3 with a heart failure history has a 50% event rate in those first 3 months. And it is generally death or hospitalization, right? And obviously the 4s and 5s, almost 80% here have an event rate. So, if you're strapped for resources, you quickly set up a system so that you look for these criteria, and then you look at the CHESS score, and then you know who may have heart failure, but also who you need to see first. Just like our fellow who was crying out at night. He had a high CHESS score. From the clinical perspective, these are probably the best criteria in a long-term care setting. They're fairly specific. And I like them because they're logical. There's a history part, there's a physical exam part, and there's a chest x-ray. Everyone's got a chest x-ray coming into a nursing home. They may not have edema, but if their heart's enlarged, look at that, you get 3 points, okay? So if they're obviously short of breath, then that's a problem. Orthopnea, they may not complain of it, but I like to examine them lying flat. And I talk to them while they lie flat, and they start struggling. That's an orthopnea equivalent. And JVPs are hard to see. I agree, but if they have crackles, you can see the crackles doesn't really help too much, but they're wheezing. And if you're really good, you detect an S3. Their JUP is obviously visible and high. Essentially, you've got this scoring system. You can have up to 4 points for each section. You add them up, and this helps you in terms of your certainty about the diagnosis. And the beauty about this is you don't need to send off for blood work for a peptide, which will take a while to get in there. You've got the chest X-ray on admission. Often there's some effusions, often there's a big heart, and if they have some of these features, then you have enough to go to the bedside. What about the PSWs? Well, this was developed by an advanced practice nurse in the US, and we tested it out in an intervention, and this works really well for PSWs. We have these little pocket cards that are done, and essentially it's a little mnemonic, a new leaf, and it describes some of those atypical symptoms. And they're useful for huddles, they're useful for shift change, and so the teams can talk about these things, and the more symptoms they've got, then they can go to the nurse and say, look, I think we have a problem. We have 4 or 5 out of these symptoms. Someone needs to assess this person for heart failure. And again, it's fairly specific and very useful. And when we did a pilot study in some of these nursing homes, they found it extremely acceptable and easy to use. And essentially what you're trying to do is work with your team to assemble this puzzle. That's what you're ultimately trying to do. So that's the diagnosis. The weights, again, weights reflect generally fluid retention. In long-term care, we worry more about nutrition. We should, but sometimes the weights change really fast. And this study was done in a randomized trial in the community, and they found that weight change occurred 30 days before hospitalization. The symptoms happen here at the very end. And so, do you need to do daily weights? No. When we did our pilot work, we found that doing it twice a week at bath time was enough. And teams were happy to do it a bit more if the patient was just unstable. If the patient's been really stable, you do it every week. Remember, if you've got a well-trained team of PSWs that are doing the new leaf and checking in with the nurses, you've got some redundancy here in terms of the monitoring. So monitoring weights, finding the dry weight. So that's really important because I've seen many people weigh patients with heart failure, and you can see the weights go up by 30 pounds, and no one's done anything about it. And so they just record the number. They have to have a reference, a dry weight. And so a clinician, nurse practitioner, physician, you can figure out what the dry weight is if, they don't have orthostatic hypotension, their BUN creatinine ratio is okay, their edema is minimized, and they're feeling good. And then you pick that's your target. And if it deviates more than a couple of pounds a week, then you reassess. You should always reassess the dry weight overall on an annual basis because people lose weight or people gain weight, right? They have dementia and heart failure, they come into a nursing home, and now they're eating regularly, so they'll put on weight. So you want to make sure that you review your dry weight once in a while because otherwise, hey, they're gaining weight, increase the diuretics, and all of a sudden they're in kidney failure. So you want to make sure that that's part of your processes to reassess. And like I said, twice a week at bath time is probably fine. Cardiologists throw conniptions when we say that, but they need to work in long-term care and find out for themselves. And if someone's stable, once a week is okay, right? But the key is getting your team to understand the condition. They don't have to be physiologists, but they can really learn how to understand the symptoms. Shift change. So again, in some of the work that we've done, we've created this when people have huddles. This is the heart failure zones. Green is good, red is bad, but we built in the new leaf here. And so people can sort of look at this in terms of what's the person's weight. It's gone up and they have symptoms. You can go to the nurse, then the nurse can go do an assessment and bring in the nurse practitioner or the physician. Again, it's not classical palliative care, but it's a palliative approach to care where you monitor symptoms of a rapidly cycling condition, you address them. Physician rounds, again, you can build in the new leaf to that. And so if you come in as a physician and you have something that says there's 4 out of 5 new leaf symptoms, you've got something to go with, right? Okay, let's go check their volume status. And so how do you do this? You've set up these processes, you've set up your quality indicators, and then how do you do this? And so we developed this with stakeholder input, and we can provide you with the references if you want. But we did work with long-term care teams, with PSWs, RPNs, NPs, and physicians and pharmacists and family members of how do we jimmy the heart failure guidelines into the care process and into long-term care. And so the basic themes really boils down to communication. You've got to get that figured out. And knowledge gap. And again, we're not trying to turn everyone into physiologists, but I remember some of the PSWs in the first iteration of our education thinking that heart failure happens in the setting of constipation. I guess you can have a heart attack if you strain, but there's some basic knowledge that you can provide people. Workload issues and communication with specialists, that's a separate story we need to talk about later, but there's a lot of stuff you can do with your team because that's where the main determinants of care quality are. And so we developed this intervention where we provide the education and we have a workshop with the physicians and the teams separately. And in the end, we provide this education and we go to the bedside. Let's go see so-and-so with heart failure, and we examine this person together. And it's really neat. We just let everyone listen to the heart and to the lungs, and they've heard a murmur for the first time. But sometimes we pick up heart failure, we order some diuretics, and in a couple of days, the patient's better. And you can go back to the team and say, look, you found this problem, you got the person treated, and now they're better. And so that's the nice thing about heart failure, because treatment works quickly. And so in terms of pedagogical value, it's really kind of useful. And in the end, the whole idea is to make sure that once in a while, as a clinician, you go around with the team and you talk about so-and-so and you talk about their heart disease and you listen to the heart and you discuss whatever that person needs to have discussed, treatments, advanced care planning, wishes, and so forth. It's really going back to the rounds at med school. And you can do that very efficiently as a physician. So what we found is the education was feasible, acceptable, everyone learned, and the teams really came together, and we were detecting heart failure very early. And this exemplar that I want to talk about very briefly, again, this was a resident who was admitted from hospital as palliative dementia. And this person was total care, Hoyer lift, very delirious, and the team applied the new leaf symptom list, and he had 5 of the symptoms. So they talked to the physician. They gave this person diuretics. They weren't expecting to resurrect Lazarus, but that's what they ended up doing. So they treated the person's heart failure. His confusion got better. But as they did that, they found that he got more and more strength. And eventually, after a couple of months, they gave him some rehab. And a few months after that, he was up and walking with a walker. And he lived another 9 months with excellent quality of life. But the beauty about this is the team gained the trust of the residents and the family. They were very impressed. And when he finally got sick again, he was palliated in the nursing home. So it was really neat. I mean, from a cost savings perspective, he lived another 9 months. And perhaps from the bean counter perspective, that's expensive, but it's exemplary care. So the essential ingredients are nursing and PSW education, physician education, multimodal, bedside teaching, and one of the important things is to get external consultants to come and round with the team once in a while, every month or so. Have a heart failure day. And that's a very good mechanism for knowledge translation as well. You don't have to call for a consult. The physician comes in. And if the physicians are worried about billing, it's not an issue. I can tell you that. Eventually, they will die. And so there's three modes of death. Sudden death, and that's generally painless and quick, unless you have a defibrillator. Um, they can be deactivated. So you need to have the phone number for your local arrhythmia clinic. They can bring in a magnet and you can turn off the defibrillator. But often unfortunately, people get these devices with no conversation about when you might want to deactivate it. And often in long-term care, if you have other comorbidities and you're suffering, sudden death would be a preferable way to go. When these things fire off, it is terrible. And so it's a very important thing to pick up quickly and identify and have a conversation. Some may die of progressive heart failure. They become very symptomatic. And again, you can hang on to the heart failure meds fairly long until maybe they start causing too much dizziness or shortness of breath, or they can't take meds. Morphine is better than benzos for symptom control. And sometimes you'll die from something else because you've done such a great job with the heart failure that, like my resident who developed lung cancer, they'll die of something else. The trajectory is the key. It's uncertain, right? So discuss early, discuss often, be honest, balance with hope. I've had residents who I thought would have died and they lived 21 months with decent quality of life, right? And so it is very hard to pick when they're going to die. And so trying to shift gears between chronic disease management and a palliative approach is tricky. But if you have a palliative approach throughout, it should be more seamless. So here's the survival with the diagnosis of heart failure. If you're coming into long-term care homes, 6 months later, 70% are still alive. And again, most of the events happen in the first 3 months. If you look at the chest score, that's why the chest score is interesting, because let's say you have a chest score of 3, 6 months later, 40% are alive. If you have a chest score of 4, 30%. And if your chest is 5, only 8% are alive. So it's very useful in terms of their health is unstable. I don't want it to be understood as you're going to die imminently, but they're very sick. You might be able to stabilize them like our fellow at Winston Park, but it's important to get there quickly and see what's going on. And so, again, think about this as a chronic illness. It does get worse over time, and the exacerbations will happen. You can't predict when they're going to happen, but if you set up your systems so that you can pick them up early through the PSWs or the family or the residents and get on top of it, you will maintain quality of life. You want to make sure that before you go ahead that you've got quality assurance set up so that you can monitor your progress, because otherwise, if you don't, out of sight, out of mind. Team education, focus on the bedside. It doesn't have to be lengthy rounds, but bring the teams to the bedside and, let's listen to the heart. Sometimes the neck veins are so interesting and obvious. I've taught PSWs how to pick up JVPs from the end of the bed. It's, with practice, you get good. And heart failure is interesting because it's a useful archetype, right? Because the rapid cycling allows you to give rapid feedback to your team so they can learn. And as they're learning together as a team, they start functioning better as a team. And ultimately, better team function is good for residents, regardless of what ails them. Advanced care planning, the conversation, I'm very honest with families that I do not have a crystal ball. I talk to them about how things might go in the future. I can say that I'm there to support them and treat their symptoms, that it's very hard for me to figure out what's going to happen to them. What do we need to do with you, for you now? If you can get them on the meds or keep them on the meds, the ACE inhibitors, whatever, if they tolerate them, they are good at symptom control. And remember the atypical symptoms, because if you can't diagnose it, you can't manage it. And so again, we're coming to the end. This is all about, I'm interested in collaborators. I want to start working on things like that and learning from your learning so that we can start optimizing this. And hopefully with the group, rope in some specialists into helping out into long-term care. And Dr. Paul Hebert, I collaborate with him, as does Ben Robert, and we have been provided CIHR funding to develop a clinical trials platform for long-term care. And that's one of the things we're interested in doing is palliation and heart chronic disease management and so forth. So I'm happy to take questions.
We have a few minutes if folks have some questions for Dr. Heckman.
I am just wondering if you could comment on getting the buy-in from frontline staff, especially in today's current um, environment with turnover agency staff, just trying to keep
Yeah,
keep the place afloat and trying to activate a new change.
it depends on your team. And so the first thing is the director of nursing and the physician and the nurse practitioner, right? You've got to be on boards. And some of the early the early work we did as researchers, we were assigned a nursing home by the head office. They never talked to anyone about it. And we showed up one day and the physician said, "Who are you and what are you doing here?" That didn't go well. And so if you're going to start, you probably pick a home where there's stability and you know people. And you may want to pick one neighborhood, one unit, and start there. And so, again, what I found was interesting is we had the in-service on heart failure, and that's how we got our volunteers. You know, a lot of people say, "Oh, that's so and so. Oh, my husband has this." We've actually helped some PSWs have their husbands diagnosed with heart failure and feel better. And so, having the in-service done in a way that is tailored to them, you will get volunteers, and that's a good way to start. Start small if you can, and get your, the interesting thing is the champions come and go. You really want the team to come together. You want to have PSW champions and RN champions and RPN champions and the leads, and the administration has to be on board too. So that's why you want to do the preparatory work first, and then you get the onboarding because people really get it. You teach it in a way that they understand it, and they start thinking of residents who might have heart failure. And in general, they're correct. You go to the bedside and say, "Hey, well done, you got it." So it's really the reinforcement, which is the great part.
George, there's a question that came through in the
Yeah.
chat. Can you speak to spironolactone versus metolazone for treatment after Lasix is maximized? Is there one you would choose over the other?
So that's a very good question. So spironolactone is used in two ways. At the doses that are in the guidelines, it's like low doses, 12.5, 25/50, and that's a disease-modifying dose. And so what spironolactone does is it prevents cardiac fibrosis and it helps the heart function better over time. Lasix being maximized, it really depends what you mean by maximum. 80 to 120 twice a day, that's a pretty hefty dose. And usually around then, I will resort to as needed metolazone. The metolazone's tricky because if you use Lasix with metolazone, you've essentially set the person up to be unable to retain any sodium at all. And so their diuresis is going to be massive. And so with metolazone, what I do is I usually try one or two very low doses every other day for a couple of days. And often what you'll see is they will lose 5, 7, 8, 10 pounds. And they'll feel crappy. And that's why we do it every other day, because all of a sudden their intravascular space is depleted. the edema has to follow. It takes a while to come back. And so metolazone probably the way to go. Sometimes, despite that, it's hard to get diuresis. There is a drug called Buranex. It may be covered on special release. Buranex is interesting because the dose is generally 10% less, or 1 milligram of Buranex is equivalent to 40 of Lasix. And it works extremely well, but it's expensive. But I think if you're looking at that kind of combination, especially if people's kidneys are starting to fail, you're probably getting to that knife edge when if you treat the heart failure, the kidneys pack it in. If you back off, the heart packs it in. It's time to have another conversation about advanced care plans. And again, that's when a specialist may be able to come in. But that lady who survived 7 years, that's what we did. She was on 120 of Lasix twice a day with the odd metolazone, and we managed it that way. But again, when doses escalate, you have to ask yourself why. And it's probably important to say, look, your kidneys are starting to fail, the heart's failing. We're getting close to when we won't be able to manage this very well. And some people have been sent to hospital for IV Lasix because they weren't sure and they felt better. And 3 or 4 weeks later, we were back where we started and they realized, okay. But again, it's easier to have that kind of discussion if you've had this kind of discussion all along. Spironolactone, as an aside, for people with preserved ejection fraction, which is the bulk of these folks, combined with SGLT2 inhibitor, the SGLT2 inhibitor keeps the potassium, the hyperkalemia problem away to a certain extent. So they're good given together because then it helps protect the person from hyperkalemia. And as far as using it in long-term care, as long as the peri hygiene is good, we haven't had issues with the yeast infections. And they feel better.
We probably have time for one more question. Anybody?
Let me just say thank you. This was particularly relevant. My name is Julia. I'm a nurse practitioner in Belleville in the inpatient setting, transition care, and I've had a patient who has had ongoing delirium for weeks, and we can't figure it out. And I'm so excited to go to work tomorrow and go see her and assess for heart failure. I had never thought of that as being the cause. So this has been great.
You're welcome.
Thanks, Julia. That's a great way to end. And yes, Dr. Heckman, I think your presentation was excellent, and I certainly really appreciated your emphasis on the interprofessional team and, looking at this as a way of improving practice overall. And yeah, I bet you'll have some takers of folks that might be interested in joining you on your research quest. So that's
Absolutely.
very exciting.
Drop me a note.